Thank you very much. It's a privilege to be speaking at this important meeting. So in the next few minutes, I'm just going to give an overview of some of the milestones that we've had over recent years, and in fact, going back several decades in the management of thalassemia syndromes. So I'm going to start by talking about the scientific understanding of hemoglobin disorders just very briefly, because that underpins any treatment advances. Then I'm going to go through the chronology of thalassemia treatments over several decades to see how transfusion...
Professor Porter, sorry, the screen is not shared.
Is it not? Okay, no. Let's try again.
Thank you.
Thank you, Professor Porter. We can see the screen now. Thank you.
Okay, thank you. Okay, I hope you can see the screen clearly now. Is that okay?
Yes, it's perfect. Thank you.
Thank you. So, thank you for that introduction. It's a privilege to be speaking at this important meeting. I'm going to talk about some of the milestones in thalassemia treatment over recent decades. And it's not advancing. So I'm going to start by talking about the scientific understanding of hemoglobin disorders, because they underpin any advances in treatment. Then I'm going to go through what's often referred to as standard treatment, which has been transfusion combined with chelation, how this has led to significant improvements in quality of life and also in survival. I'm going to talk about how that compares with bone marrow transplantation as a curative option. And then I'm going to touch very briefly on emerging therapies, because there's several of these coming through, and these could have a significant impact both on quality of life and on outcome. So here we can see a chronology going back to the 1920s, right through till today. And we can see that the condition of thalassemia was first described by Cooley in 1925. Although the clinical description was made, the understanding of the processes underneath it was really very incomplete. And during the 50s and 60s, the structure of hemoglobin was understood, and the fundamental idea that thalassemia resulted from imbalance in globin synthesis. Normal hemoglobin contains balanced amounts of alpha and beta globin, and if you don't make enough of one of those, then this damages the developing cells in the bone marrow and also any cells that are then released into the blood. And another very important set of advances occurred in the 1980s when the genetic underpinning of thalassemias was really worked out. And it became clear that there were over 200 different beta thalassemia mutations, for example. And due to other advances in diagnosis, it then became possible to do prenatal diagnosis on very small samples of chorionic villus as early as 10 weeks of pregnancy. And this then opened up the whole prospect of doing antenatal diagnosis with disease prevention, which is a critical part of the overall management of thalassemias. Now, you can see in the bottom now how that links in to changes in treatment. The blood transfusions really became available in the 1950s and 1960s on a regular basis. And this led to iron overload, and we needed treatment to remove the iron. And the first drug that was given was desferrioxamine. This has a very short half-life, and as a result, needs to be given what we now know as an infusion, but that wasn't known initially, so it didn't work very well until infusions came in. Bone marrow transplant as a therapeutic option, curative option, came in first in the 1980s. I'll talk a little bit more about that. And then one of the problems with desferrioxamine as a chelator is that it's not effective by mouth, it's actually given as these infusions, and oral chelators came in the 80s and in the new millennium. So we now have two oral chelators, deferriprone and deferricyrox. Both of them need to be managed quite carefully. Another very important advance in the overall management of thalassemia was the development of MRI or CMR to measure iron both in the liver and in the heart. And we now have a much better understanding of the links between tissue iron and tissue damage. So this has been very important in the overall management of patients. Curative options have always been a goal, and one of the problems with allogeneic bone marrow transplant has been hitherto it's only been really available to people who've got a brother or a sister who are a complete match. And so the idea of gene therapy, which in principle could be available to all patients, has been a long-term goal. We've now got very exciting new data on its use in thalassemia, which I'll touch on very briefly. So let's try and go forward. Another important thing to say is that I alluded to the fact that people are surviving longer, but you can see the figures, in fact, in the 1980s, 2000, then from up to 2010, the number of deaths per 1,000 patient years has fallen from 12.7 to 4.3 to 1.65 in countries which have access to both safe blood and affordable chelation. And that's a very important part. We need to work on that on a global basis to make it available to the widest possible number of people. And these are some examples of improvement in survival curves in UK, in Italy, and in Greece. And you can see that in birth cohorts, the survival has significantly improved since the 1960s right through till today. It's not perfect, and that's one of the reasons that people are still looking for improvements. It's very challenging treatment. Blood needs to be given every 2 to 4 weeks. Patients need to have chelation therapy, and it needs to be monitored, both in terms of overdosing and underdosing. It's very demanding, and obviously everyone would like a simpler treatment, but it does work when it's taken. And here you can see a scheme of what's happened to some of the complications from thalassemia over the years. So you can see in the 50s, people were really dying of anemia, as shown in the pink. And as we go into the 70s, you can see that people started to die from iron overload. This is mainly iron going into the heart from blood transfusion. And it was only as chelation became more available and easier to take that survival improved. So you can see that current cohorts, mortality from iron overload, mainly from heart iron, has gone down very significantly. And the main causes of mortality now, excuse me, relate to the liver, hepatitis C, and in fact to infection and malignancy. So that it's been, and the overall mortality, as we've already seen, has dropped very significantly. The age distribution in cohorts where these kinds of treatments have been available has changed. This is just a snapshot from our own clinic showing that the age distribution has changed from 1975 through to 1985. They're becoming younger. There are very few patients under the age of, say, 15 in the UK, because we have a very effective screening program for thalassemia. So the distribution curve will not only depend on treatment, but also on prevention. There are remaining issues with thalassemia, however, and there are various reviews, and I think the work of Tiff here is going to be really helpful in defining what the remaining issues are with a little more focus. This figure I give at the top here of 12% of children with transfusion-dependent thalassemia receiving adequate transfusion therapy. This is from a review by Bernadette Medell. And it's actually very difficult to put this data together in a reliable way. But that's a shockingly small percentage of patients who could receive transfusion who are getting effective transfusion, if those data are accurate. And less than 40% of those who are transfused actually get adequate chelation therapy. So that's another issue. The treatment is expensive. The cost varies from country to country. In the UK, for example, the lifetime treatment cost up to the age of 50 is somewhere in the region of £500,000, very expensive. And then when we're developing new treatments, we have to bear that cost in mind to see how that relates. So in fact, when it comes to bone marrow transplantation, the cost of transplantation, depending on the country we're thinking about, is somewhere in the region of 5 to 8 years of regular treatment. So a curative treatment could, in principle, have an advantage. The other demanding thing about transfusion chelation, it needs to be maintained throughout life. If there is a period of time when the individual is unable to take regular chelation, regular transfusion, this can have a permanent impact on quality of life and actually survival. So there is a need for curative therapies, and the first one that was developed was stem cell transplantation, which I'll just mention briefly, and then I'll also mention gene therapy. So stem cell transplantation was first introduced in 1982 by Lucarelli's group in Pesaro in Italy, and he developed a risk classification which allowed the identification of patients who were better or worse risk and help make decisions about the timing of transplantation and the selection. It's clear that transplantation needs to be done early, and the survival is much better in those who are transplanted before the age of 5 to 7 than those subsequently. Survival has been improving over the years. So the European Bone Marrow Transplant Registry has shown that long-term survival in sibling matched transplantation is in the order of 91%. Increased experience has now been gained in adults, also with matched unrelated donors, and also with haploidentical transplants. These we don't have time to explore in detail, but the scope of transplantation is increasing. There are other approaches. So what are they? Well, there's improvements in non-curative management. I've alluded to the use of MRI. There's improved safety and provision of blood. A lot of work's going on to try and find better ways of screening for infections in blood, for new ones that might develop in the future. And then there's non-curative therapy with drugs. And I will mention one of these, luspatercept, which is a very interesting drug which improves the quality of red cell production. There's interest in many drugs that relate to manipulation of hepcidin and manipulation of iron delivery to the bone marrow, which can improve the quality. Gene therapy has already been successfully shown with lentiviral vectors, and there are trials ongoing now with different types of vectors called CRISPR. I'll just mention that. And then as I mentioned, we're also improving the quality of stem cell transplantation. So gene therapy was first thought about in the 1980s. Progress in understanding beta genes occurred in the 1990s. And there were some initial problems with lentiviral vectors with unwanted serious side effects, but these were sorted, and there was a revival in their use in the 2000s. The first patient to be successfully transplanted using a lentiviral vector was in 2008. And this is the patient who's maintained successful transfusion-independent survival since that time. So this was a very exciting identification in a patient with hemoglobin E beta thalassemia. The principle of gene therapy is to introduce a gene correction ex vivo outside the bone marrow by collecting stem cells and then reinfusing the corrected stem cells into a patient who's received myeloablative chemotherapy. At the moment, that has to be given with busulfan, and then hopefully will be advances in future using other forms of myeloablative therapy. So the patient is regenerating from their own bone marrow, and that reduces the risk of graft versus host disease, for example. So these are some recent results with what's called commercially as Zynteglo, developed by Bluebird Bio. This has completed phase 3 pivotal trials in non-beta 0 thalassemia, so the less severe forms. And the mean weighted hemoglobin in steady state post transplant is about 12, so very good levels of hemoglobin. And 72% of patients have been able to stop chelation therapy as well. It's received a view from the European Medicines Agency, which says that it is indicated in patients 12 years or over with transfusion-dependent thalassemia of the non-beta 0 genotype. We hope that when the data on the beta 0 comes through, that recommendation will be widened. The problem with this is it's very expensive at the moment, and it hasn't been adopted very widely yet, partly because of those considerations. Finally, there are non-curative innovations which are coming through, which I'll just touch on. We can improve the hemoglobin production by having fetal hemoglobin promoters. We can have manipulation of iron in the body, which improves the quality of erythropoiesis by manipulating hepcidin through various mechanisms. And there is this new drug called luspatercept, which decreases the amount of ineffective red cell production. So this is going to be my last slide. And luspatercept is an activin receptor ligand trap that has been shown to improve late stage red cell production in the bone marrow. It's just completed a phase 3 study in over 300 patients over 18 years of age against placebo. And the primary endpoints were reached in 21% of patients with a 33% reduction in transfusion burden, and 11% of patients became transfusion independent. It was actually remarkably well tolerated, and it's been approved by the US Drug and Food Administration and the European Medicines Agency. This approach is probably also going to be very helpful in managing patients who are less transfusion dependent, but are also anemic, such as E. thalassemia patients. So I hope just quickly we've gone over the history of standard treatment with transfusion chelation, the development then of bone marrow transplantation, its future going forward, possibly offering a treatment to a wider range of people, and then new curative approaches with gene therapy and new drugs to improve the quality of red cell production in patients with thalassemia. Thank you very much.